Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. So I am back from Napa and actually tired and trying to recover from there, but the show must go on, and I am actually excited to be back and to talk to all of you. And so one of the things I wanted to talk about today is I was getting a couple of questions, which the question kind of surprised me at first, but then I thought, you know what, with all of the vague guidelines, I can kind of see where maybe the definition could get lost. And what was coming up in a lot of my feed this week was providers wanting to find a definition specifically on what, and I'm air quoting, what patient-initiated means. So I know a lot of you probably think, well, that's self-explanatory. The patient's the one that called. But they like to see it in writing and where you can find that information, even when we may think it's common sense. So I did find kind of an interesting cited area, and it was actually UK, and I noticed that I have a couple of MAC carriers that took the United Kingdom information on the patient-initiated follow-up, is what they call it, PIFU. And I thought this was a really good definition that can help you when you're determining whether an eVisit, so the digital visits that are through the secure email or the patient portals, is appropriate, or if an audio only is appropriate. And so here's what it says. It says to give patients and their caregivers the flexibility to arrange their follow-up appointments and when they need them, so AKA patient-initiated follow-up. So they said it's when the patient initiates an appointment when they need one. So based on their symptoms and individual circumstances. So the physician does not call them or check in on them or contact them specifically to schedule an appointment or to see how they're doing. If that's the case, then there is no audio-only visit or eVisit, because that would not be appropriate, because it would be physician initiation. And let's face it, prior to the pandemic, we did not do that. So this can be kind of applied to patients with longer short-term conditions, can be applied in a broad range of specialties, could be, derm, rheumatology, cancer, cardio, but it's really, not a new concept. And I'll get back to the acronym PIFU, patient-initiated follow-up. And you can see it doesn't mean new patient, because obviously new patient visits now are not allowed for audio only, because you have to have the definition of the phone call code, which does not say it's allowed for new patient. It's not allowed for the check-ins that they gave you and that actually were effective prior to the pandemic, and you can't have them also for eVisit. So we're not talking about new patients here. We're talking about established patients where there is a care plan in place and they know what the physicians have told them in the past under that care plan, that, if you feel this, if this is a problem, if anything happens, then this is what you do. And so it's not a new concept. And sometimes it goes by other names. You may have heard it called open access follow-up or patient-led follow-up, even patient-triggered follow-up, patient-initiated appointments, maybe supported self-managed care and follow-up. So those are also some things that you may hear it called. But this approach helps really empower patients to help manage their own conditions, and helps to play really a key role in enabling shared decision-making and supported self-management of patient symptoms where they have some chronic conditions, and they get to really help decide if this is the time to initiate that care, whether it is through the patient portal, not just to check on a lab result, but to get correspondence back and forth from the physician, or through an audio-only option, where that is an option still, but you want to make sure that you also have documented that an audio and video was not available, or that the audio only was the most appropriate. Remember, one of the things that, and I keep kind of mentioning it in any webinar I teach, post-PHE rules, any post-PHE telehealth, is that in the March stakeholder call from CMS, Jean Moody Wilkes, who is one of the directors in Medicare who helps present that information, she said, and I'm quoting here, discontinue use of waivers when no longer needed. And so what that means is that it's not needed anymore to have a new patient audio only visit. That's why they're not allowing it. It's not needed to have a new patient virtual check-in audio only. That's why they don't allow it. They want at least new patients to get back in. And you're inviting risk if you don't recognize that now that the PHE is over, I should say. And so understanding what patient-initiated follow-up is, where it's actually the patient now that they're initiating the appointment based on their symptoms and their current individual medical circumstances. And so they're the ones that say, you know what, I need an appointment, whether it's audio only or I need to go into my portal and determine what's going on with me because maybe I have an upcoming specialty appointment and I need all the information that I didn't feel that I got in person. So I need to have some correspondence with my primary care doctor or with my family practice doctor. And I think once you keep that in mind and understand that there are specific definitions when it comes to patients that are initiating their own care, I think you'll be protected and probably feel a little bit more comfortable when submitting those codes. Now, in saying that, you have to make sure that it's well documented. And if you're dealing with the eVisits, the portal visits, then you have to have total time cumulative in a 7-day period. And then if you're dealing with audio only, don't forget the definition. You can't have had a visit within the last 7 days or related visit next available appointment in the next 24 hours or as soon as available. So you have to really keep those things in mind when you're scheduling these services. I can't tell you how many emails, questions, inquiries I'm getting lately about why can't we see a new patient for an audio only? Well, why do you need to? We are no longer under the threat of a public health emergency. Regardless of the percentages out there of COVID, the flu, all different things, we are no longer under a public health emergency. That was for the height of the pandemic when we were told to stay home, when patients with compromised immune systems were saying, were told not to go into their doctor's office, but patient needed care. Well, 3 years later, we can't now justify not seeing a patient, especially a new patient, in person if it's appropriate and when it's appropriate. And so just keep that in mind because you could be coding and reporting services incorrectly if you don't know some of the definitions and understand the rules down to the letter. Make sure you're not just, kind of glossing over the rules. Otherwise, that can be a problem as well. Okay, so I'm just going to do that's just a quick one today. I do have an interesting coding question that I would like to also include. And I thought this was, it took me a minute to figure out how to respond to it because I have my thoughts on how to respond to certain questions. And then that doesn't work for our office. I'm like, okay. So it said, Terry, if the critical care note reflects a mid-level was involved, yet he or she did not document their time, but the physician documented, I spent 35 minutes in critical care time, excluding procedures. Can the service be billed under the physician, or is it defaulted to be billed under the mid-level? Or is critical care not supported since it's unclear if the mid-level had more time or not? Okay, so talk about a mess. And if you ever listen or watch the compliance roundtable with all the 5 of us talking with Sean Weiss, this is going to come up next week. But I thought this was such an interesting question because for me, I get certain things like this, and also I get these continued shared visits in the office, which are not allowed by Medicare, and I don't let the doctors have them. I'm like, if you're going to continue to add language that's non-compliant and AMA and Medicare has said stop putting this in there, then for me, it negates the record. So the question comes back that, what do you do with this? Well, if the doctor spent 35 minutes, then obviously there is something to bill here as long as it meets the criteria for critical care. But my problem here is that since the note does reflect that there was a mid-level involved, who had more time? And in the critical care, it's a time-based code. So since that wasn't there and I don't know, can I bill for it with that FS modifier? Because remember, the FS split shared modifier still has to go on it. And just because the doctor was the one that, put in the 35 minutes, we don't know how much the mid-level did. And the only good thing here is if it hasn't been billed yet, then there can be a late entry, a correction, or an addendum. If it's already billed, you can't add something post-billed. But go back to that. I would do a query. I'd go back to that mid-level provider and say, how much time did you spend? And I would not query it in the doctor said 35, so how much of that did you spend, or did you spend more than that? Do not ask that question, because as soon as you do that, now you've got a tug of war who gets to have the visit and who gets to have the critical care. Just ask the question you're querying, and hopefully they'll be honest with their answer. But I would query before I would bill that, because it is going to need an FS modifier. It's non-compliant when you know that it was a split shared visit. And let's just say you submitted it as just a physician bill without the modifier, or even with, but there is no mid-level information in there. You could get into some trouble if it's ever audited, and hospitals are audited all the time. And they audit what the physician does as well. So you have to be very accurate now in your coding, your reporting, and your documentation. And it's not like you didn't have to before, but I'm noticing that CMS and Medicare, they're looking to take money back because there's such an overspending right now of government funds. And so they're just like, where can we find bad faith? Where can we find money that we can just say, no, you were non-compliant? And this is low-hanging fruit. So please don't invite this risk, and make sure that if this does come up for you, that you are clear with your mid-level providers and your physicians that if you're going to build time-based codes, both of you have to have the time in there, especially if you're going to share the visit in the hospital, since it's not allowed in the office setting. Okay, so that is my wrap-up for today. I hope everyone had a good weekend last weekend, and you'll have a good rest of your week. And thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.